Okay, so let's move on to part 3 of the general surgery review. Question 21, on the medicine floor, you are managing the general health of a 64-year-old male. He was a long-term alcoholic, sober as of 3 years ago, and an active 40-pack year smoker. He was diagnosed with hepatocellular carcinoma 3 years ago. He underwent resection and chemotherapy and is presently in remission. He was in his usual state of health until about a week ago when he was admitted for unexplained weight loss and bony pain. Which of the following biomarkers is most likely to yield significant results for this patient? A. PTHRP, B. Alpha-fetoprotein, C. CA19-9, D. Beta-HCG, or E. CEA. Alright, I'll give you some time to pause it here. And the answer to this question is B, alpha-fetoprotein. So this question simply asks you about your knowledge of biomarkers, tumor markers for certain cancers. And it requires you to know that the marker for hepatocellular carcinoma is alpha-fetoprotein. These other markers that are here are also very important markers to know, but they are not associated with hepatocellular carcinoma. So that having been said, what are some tumor markers, biomarkers, and associated molecules with cancers? Okay, I'm going to preface this with not all of these are perfectly specific or perfectly sensitive to all the tumors, but they are sort of buzzwords for the tumors. So it's good to know the association, that there is an association to some extent, some more than others, with these markers and the tumors that are associated with them. So this question had asked for alpha-fetoprotein. Alpha-fetoprotein is associated with hepatocellular carcinoma and testicular cancer. All of these are associated with possibly some other things too, but I only put on the most common things that you'll see. So alpha-fetoprotein, most commonly associated with hepatocellular carcinoma and testicular cancer. The BCR-ABL fusion protein is associated with some forms of chronic myelogenous leukemia, and this is an important marker to know because this creates a protein that drives the CML. BRCA1 and 2 and the HER2/neu oncogene are associated with breast cancers. These aren't serum markers, these are just genes that are on the tumor, but you need to be aware of these as far as treatment and therapy and planning for management of breast cancer. CA125 is associated with ovarian cancer, CA19-9 is associated with pancreatic cancer, CEA is associated with multiple different GI carcinomas, especially the colon cancer. It's also associated with medullary thyroid cancer and pancreatic cancer. HCG is associated with the gestational trophoblastic neoplasia, which is an OB/GYN cancer. It's also associated with choriocarcinoma and testicular cancer. PSA is obviously associated with prostate cancer, the prostate-specific antigen, and S100 is associated with melanoma. So if you know these, you're pretty much set for the USMLE. But the really important ones I would say to know are the alpha-fetoprotein, the BCR-ABL, the CA125 and CA19-9, and the CEA are probably the most important and also the most commonly forgotten. Most people know that prostate-specific antigen is associated with prostate cancer. So, but I would remember these. So, like I said, the must-know are hepatocellular carcinoma being associated with AFP, pancreatic cancer being associated with CA19-9, GI cancers, especially colon, being associated with CEA, carcinoembryonic antigen, ovarian cancer being associated with CA125, and prostate cancer being associated with beta-HCG. This is by no means an exhaustive list, but this is just a foundation for the test. All right. Question 22. A 19-year-old female in your clinic is in for follow-up on her chronic reflux symptoms and associated abdominal pain. You first saw her last year where she had complained of typical GERD symptoms of 2 months duration. You recommended lifestyle changes as she was overweight and avoiding trigger foods and avoiding food or drink within 2 hours before sleep. Your standard recommendations for a patient with GERD, lifestyle changes. She returned 3 months later, having followed your advice and was now at a healthy weight, but was continuing to have symptoms on a daily basis. You ordered H. pylori serology, which returned negative, and started her on omeprazole. She again returned 3 months later and says she's continuing to have symptoms. You referred her to a gastroenterologist for endoscopy, where they found distal esophagitis consistent with Barrett's esophagitis. Biopsy is currently pending, but there are no visible ulcers or H. pylori on gastric biopsy. Which of the following is the most likely the best next step in the management of this patient? A. Nissen fundoplication, B. Billroth procedure, C. Modified vagotomy, D. Vagotomy, or E. Antrectomy. And here the answer is A. The Nissen fundoplication. So here you have a young woman who has gone through all of your symptoms and problems of GERD. She's been managed completely appropriately. You start out with more conservative measures, gradually stepping up the treatment, eventually sending her off to a gastroenterologist, but nothing seems to really be working. Furthermore, on endoscopy, you find Barrett's esophagus. This is a problem in anybody, but this is really a problem in a 19-year-old. Remember that Barrett's esophagus is directly correlated with adenocarcinoma of the esophagus, and it's just a matter of time in many cases that eventually Barrett's esophagus will have a malignant transformation. Like I said, it's a problem in anybody, but when you have a 19-year-old and she's already got Barrett's esophagus, this is a big problem because she'll almost certainly at some point, if she lives a long, normal life, at some point she will develop esophageal cancer. No matter what, if a patient has Barrett's esophagus, we want to do some kind of procedure, probably also including an esophagectomy, a distal esophagectomy. However, what we want to do, even though and we don't have the biopsy yet, so we don't know for sure if it's Barrett's, but what we for sure want to do is some kind of surgical management. Since she's failed all the conservative therapies and the medical management for GERD, we need to now do a surgical management. And the surgical management for GERD is traditionally a Nissen fundoplication, which can be done laparoscopically. Like I said, if the Barrett's comes back on biopsy as actually Barrett's esophagus, we will do a distal esophagectomy. However, we don't know that it's Barrett's for sure yet, so what we're for sure going to do, though, in the meantime, is a Nissen fundoplication because she has failed medical therapy, and so the next step in therapy then is going to be surgical therapy. I would have you know that the rest of these are surgeries that are done. However, they're not done for reflux disease. They are done for ulcers, refractory ulcers. So the Nissen fundoplication, prior to surgery, the surgeon is going to want a for sure diagnosis of GERD. So as if the symptoms and history isn't enough, the surgeon is going to want to make sure that you've done an EGD with biopsy of the distal esophagus, which we've already done in this patient, that you've done pH monitoring, that you've done esophageal manometry, that you've done a barium esophagram, and that you've done gastric emptying studies, so that you're ruling everything out because we don't want to do unnecessary surgery. It's almost certain that in this patient she's got GERD, but surgeons tend to like you to have done all the workup and exclude everything else before they go in and do the fundoplication. Like I said, this is usually done laparoscopically. It can also be done openly. And what you're doing is you're taking a hold of the fundus, which is usually up here, and you're just pulling it around the distal esophagus and wrapping it and then stapling it together. And what that does is it provides mechanical support for the esophageal sphincter. So here's your procedure. Just pulling it around and stapling it to the other side. And it's giving you your support for the distal esophageal sphincter. So here's a really beautiful illustration of what you look like after a nisimplantation. Question 23. A 49-year-old woman presents to the ED complaining of quote-unquote constipation and abdominal discomfort over the past day and a half, roughly the same time since her last bowel movement. She has tried 2 different kinds of stool softeners, but to no avail. Her medical history is significant only for GERD. For medication, she takes pantoprazole and a multivitamin daily. Her surgical history includes open appendectomy at age 18, laparoscopic cholecystectomy at age 43, and an explorational laparotomy after sustaining a motor vehicle accident 2 years ago. On physical exam, you note hyperactive and high-pitched bowel sounds, mild discomfort to palpation, no rebound or guarding, and no palpable masses. Rectal exam is negative for masses, and the rectal vault is empty. The rest of the physical exam is normal. She's vitally stable. Abdominal x-rays are ordered and reveal multiple dilated loops of small bowel with air fluid levels. Which of the following is the most likely cause of this patient's present condition? Is it A, indirect inguinal hernia, B, retained surgical instrument, C, small bowel tumors, D, adhesions, or E, femoral hernia? And the answer to this question is... Oh, here's your, so this would be what multiple dilated loops of small bowel look like with air fluid levels. So, all right, now that we know that, the answer to this question is D, adhesions. Adhesions are the #1 cause of small bowel obstruction in the United States. So this is something you really have to know. The USMLE, I guarantee you, will ask you this. In the plethora of questions that they ask you, this one will come up. So, small bowel obstruction, #1 cause, adhesions. #2 cause, maybe some kind of mass or malignancy in the or tumor in the small bowel. So, adhesions are the most likely cause of this, and we also know that it's probably likely because she has an extensive surgical history. She's had an open appendectomy, she's had a cholecystectomy, and she's also had an exploratory laparotomy. So, multiple abdominal surgeries, and that puts you at risk for adhesions. Question 24. A 49-year-old woman presents to the ED complaint. Oh, wait, this is the same patient. Never mind. Okay, so she's been admitted now with the diagnosis of small bowel obstruction. So this evening, she develops a severe worsening in her abdominal pain, along with guarding and rebound. Her vitals are 125/70, heart rate 80, respiration 16, temperature 101.1. Which of the following is the best next step in management? A, transabdominal sonography, B, stat CT of the abdomen, C, start parenteral ampicillin and gentamicin and observe the symptoms, D, emergent laparotomy, or E, repeat abdominal x-ray. So you have the same patient here, but now she's developed this pain, which she didn't have before. And the answer here is D, emergent laparotomy. So you're probably going to start parenteral ampicillin and gentamicin, IV antibiotics, but that if you just do what's in C, that's not going to be enough. You're not going to just observe the symptoms. So yes, IV antibiotics are important, but it is absolutely necessary that this patient be wheeled down ASAP for a laparotomy because we are concerned now about dead bowel. The dead bowel has necrosed, and that's likely what's causing the peritonitis because it's irritating the peritoneum, and it's also what's likely behind the fever that she's got. So we're going to do a laparotomy, resect any dead bowel that's present. Now, most of the time, you might be asking, why didn't we do a surgery initially so that she didn't get to this state? Most of the time, a small bowel obstruction will remit on its own. And we just do NPO, maybe some NG, decompression, and IV fluids. But in this patient, her small bowel obstruction did not remit, and she went on to develop the peritonitis and the dead bowel. This is a minority of patients, and that's why we initially do conservative measures and just observe small bowel obstructions, but it is possible, and this is why we admit the patient and observe them, it is possible that they can have bowel necrosis, and so if they do develop the signs of that, they need to be taken off for surgery immediately. Oh, okay, so I guess I put this all on here. Didn't need to say that off the top of my head. So for diagnosis, best initial diagnostic test for small bowel obstruction is an abdominal x-ray. That will show you your dilated loops of small bowel. We had already done that in this patient. You want to get it at an upright view, not laying down, because if they're laying down, you're not going to see the air fluid levels, and the air fluid levels help us diagnose the small bowel obstruction. So you want them sitting up for the x-ray. So both upright and supine views should be obtained, but most importantly, get that upright view. CT and MRI are more accurate than abdominal x-ray, but most of the time you can diagnose small bowel obstruction with the abdominal x-ray. For treatment, we admit them and observe them, start IV fluids, NG decompression, prophylactic antibiotics, and then an antiemetic. Obstruction will usually resolve itself within 3 days. If the patient starts to have signs of a strangulated obstruction, bowel necrosis like this patient had, fever, tachycardia, peritoneal symptoms, the unrelenting pain, the increased white blood cells, and so forth, then this is a surgical emergency, as we had in this patient, and she has to be taken for resection. Question 25. A 27-year-old male presents to the ED complaining of quote-unquote pain in my butt that has been worsening over the past 12 hours. He says he has never had anything like this before. He denies recent sexual history and any other symptoms besides pain on defecation, which he attributes to this spell of pain. His past medical history includes several bouts of otitis media, impetigo, and an appendectomy 2 years ago. He is running a mild fever of 100.5 degrees Fahrenheit. Physical exam is significant for a tender, warm, red fluctuant mass, 1.5 centimeters in diameter, adjacent to the anal aperture, and there is considerable overlying erythema that extends several centimeters around the mass. On his chart, you note that as a child he was diagnosed with congenital neutropenia, which is not uncommon, just to let you know. Routine labs are ordered and are unremarkable. Which of the following is the best next step in the management of this patient? A, incision and drainage. B, incision and drainage plus cephalexin. C, cephalexin. D, lower endoscopy for suspected Crohn's. Or E, rectosigmoidoscopy. And the answer here is B, incision and drainage plus cephalexin. Now, in a normal patient with, and this is a patient with a perianal abscess, in a normal patient who doesn't have significant surrounding erythema, definitely if they don't have the if they don't have congenital neutropenia, which puts them at risk for a much more severe infection, a lot of times you can get away with just incision and drainage. But most of the time, and especially in this patient, for sure, without a doubt, you're going to also administer antibiotics. And the reason is not only because he has congenital neutropenia, which makes him somewhat immunocompromised, but also because he's got this erythema, which is cellulitis, basically. And so anytime a patient has cellulitis, we want to administer an antibiotic, usually 10 to 14 days, oral. You can use a first-generation cephalosporin, and you're good and covered there. So in addition to doing the incision and drainage, which we have to do in a perianal abscess, we'll also give him cephalexin. Now, I just wanted to point out some of the other things on here. The routine labs were ordered and are unremarkable. You can't always rely on a white blood cell count. Most of the time you can, but you can't always rely on a white blood cell count to document an infection, because a patient may have neutropenia, or they may have some other congenital or acquired immunodeficiency that hampers their immune response. And in that case, they're not going to have an elevated white count, even though they do have an infection. So the rest of these are just wrong based on the appearance of this patient, the mass, where it's at, and the surrounding erythema, which is consistent with with an anal abscess, perianal abscess. So question 26 gives us a 35-year-old male presenting to your clinic complaining of anal pain for the past 2 days. He says it hurts most while having a bowel movement and when sitting down. He is generally in excellent health and has recently gotten into a new lower body weightlifting routine at his gym, where he also works as an aerobic trainer. He has no surgical history. Physical exam is unremarkable except for a singular bluish-purple mass on the anal aperture. He is reluctant to allow you to do a rectal exam because of the pain. Which of the following would you most likely recommend as an initial intervention or treatment for this patient's most likely problem? So this is going to require you to make a presumptive diagnosis and now know what the treatment is. All right, so the answer for this question is E, sitz bath and stool softeners. So why do we do this for this patient? Well, it's based on the most likely diagnosis. So this patient has exquisite pain, and he has this bluish-purple mass, which I was going to put a picture up, but I thought that might make it a little too obvious, and I wanted this to be a little more challenging than just giving you an obvious hemorrhoid. So it may be, you may or may not get a picture on the USMLE of whatever is going on with the patient. Sometimes they will expect you to know what it is based on a verbal description. And the verbal description here is a singular bluish-purple mass on the anal aperture. And when they mean on the anal aperture, what they mean is right on the proverbial butthole. So right where the entrance is to the anus. And this is most certainly an external hemorrhoid. And external hemorrhoids are exquisitely painful, and they hurt during having a bowel movement, and they also hurt when they're sitting down because you're putting direct pressure on the hemorrhoid, which is painful. Another thing that leads you to believe that this is a hemorrhoid is that he got into a new lower body weightlifting routine, and straining is associated with hemorrhoids. When we see hemorrhoids in older people, it's usually because of constipation or because of some kind of process that's leading them to have an increased abdominal pressure, or even perhaps because they have an increased portal pressure, and so it's referring back to the hemorrhoidal circulation. When it's a younger patient, especially a younger male for that matter, it's usually because of weightlifting or strenuous activity. It does the same thing. It increases the intra-abdominal pressure and stresses out the vasculature down there. So this history is also consistent with the likelihood of developing hemorrhoids. So based on the diagnosis of hemorrhoids, which you can make clinically, the treatment is going to be sitz baths and stool softeners, and these are just to relieve the symptoms. Eventually, external hemorrhoids go away. Most of the time, you don't need to do anything for it. A is unreasonable. He doesn't need to not return to lower body weightlifting ever again. He can eventually return, but you may want to tell him, take it a little easier maybe. Incision and drainage, this is not an abscess, this is a hemorrhoid. If you were to cut into the hemorrhoid, it would bleed profusely. Rectosigmoidoscopy or colonoscopy, not needed. So this is an external hemorrhoid most likely, and the initial treatment plan is going to be symptomatic. 27. A 48-year-old man presents to your clinic complaining of weakness and fatigue over the past few weeks. He's generally in good health with no significant past medical or surgical history. He denies drug, tobacco, or alcohol use. His vitals are stable. On physical exam, you grossly note mild ptosis bilaterally as well as a droopy appearing face. There is +2 out of 5 strength of the upper and lower extremities with weakness more pronounced in the proximal musculature. Sensory perception is normal. Which of the following imaging tests would most likely yield results that would affirm the most likely diagnosis in this patient? Okay, so this question stem is a little bit more complicated than what you might come into in the USMLE. But basically what this is asking you is, this patient needs imaging. what is the imaging that's most likely to give you results that are going to alter the treatment plan for this patient. So that's going to require you to know what this patient likely has. All right. The answer to this one is C, front and lateral chest x-rays. So the presentation of this patient based on his facial muscle weakness and proximal muscle weakness, but especially the facial muscle weakness, is consistent with myasthenia gravis. And a very common cause of myasthenia gravis is a thymoma. Thymomas are the most common anterior mediastinal mass, and so you need to be aware that myasthenia gravis has a correlation with thymomas. If there is a thymoma in a patient with myasthenia gravis, you need to remove it. And so that's why this is very important in the workup for this patient. Even though you may have already diagnosed him with myasthenia gravis, you've got to get the chest x-rays because they will show you if there's a thymoma. And if there is, you want to take it out. That will help in the treatment of the patient. So myasthenia gravis is associated with thymoma. You can see a thymoma either on the frontal AP x-ray, sometimes, most of the time, and it's just this mediastinal mass. But a better x-ray to get, and what you always should get anytime you're ordering x-rays of the chest, is the lateral chest x-ray. So here we have a left lateral chest x-ray, and normally you have this area of lucency in between the sternum and the heart, and it's kind of a crescenteric-like shape, and this is normal. Anytime a patient has a mass in the anterior mediastinum, they're going to have whiting out of that area, which should normally be translucent. So normal, translucent anterior mediastinum, not normal. A mass in the anterior mediastinum. There's other things that can be masses in the anterior mediastinum. A lymphoma would be one thing that comes to mind. A teratoma, it could also be. But because this patient has a picture of myasthenia gravis and he's got a mass in the anterior mediastinum, this is, in all likelihoods, almost definitely a thymoma, and we're going to go in and take it out. So myasthenia gravis, just reviewing what it is, there's the history is an insidious onset of muscle weakness. A lot of patients won't be able to tell you the exact day it came on because it comes on very gradually. Most patients present with some kind of head or facial weakness, most pronounced in the eyes, like the eyelids or the intraocular muscles. It can also be in the face or the neck. You can also get weakness in the limb musculature, and it's going to be more pronounced in that case in the proximal musculature as opposed to the distal musculature. The symptoms are consistent with the history that the patient comes in with. So subacute weakness of head and neck muscles or proximal muscles. You can have intraocular muscle weakness, and that can cause some diplopia and visual changes. You can also have dysarthria, which I was going to work in to this question, but I guess I didn't. So dysarthria would be like a difficulty articulating your speech. So you may have like a nasally sounding speech, which is how these patients usually are if they have dysarthria. It's like if you were to plug your nose and talk, that's kind of how these patients sound. It's a little bit of an exaggeration, but dysarthria is a possibility just because of the muscle weakness. Dysphagia may also be present too, but the most common presentation, the minimum thing that you will have in myasthenia gravis is at least some ocular or facial weakness. About 90% of all patients with myasthenia gravis will develop ocular weakness at some point in the course of their illness, and more than half of patients with myasthenia gravis will present with some level of ocular weakness, like ptosis. When you're doing your physical examination, again, it's going to be consistent with your history and symptoms. You'll note abnormalities, especially to the cranial muscles supplied by the cranial nerves, as well as possibly some weakness of the proximal limb muscles. Most importantly, though, are two things. One, you don't have sensory abnormalities. If you do have sensory abnormalities, it's probably not myasthenia gravis, because myasthenia gravis affects the motor neurons. It does not affect the lower motor neurons in particular. It does not affect the sensory nervous system. Most importantly, though, you have a big diagnosis to distinguish them from, and that is Lambert-Eaton myasthenic syndrome. So I did a lecture with myasthenia gravis and Lambert-Eaton myasthenic syndrome in the neurology section. These can look similar, but they are very, very different as far as the prognosis and what it may imply. So myasthenia gravis, a lot of times, is something a patient just gets. Lambert-Eaton myasthenic syndrome is usually a paraneoplastic syndrome. So the way to differentiate the two of these on clinical examination is that with myasthenia gravis, the weakness does not improve with repeated use. In Lambert-Eaton syndrome, if you tell the patient to keep trying to contract a certain muscle or to keep trying to open their eye, eventually the weakness will improve for a little while. And that just has to do with the cellular pathology behind myasthenia gravis versus Lambert-Eaton syndrome. If you want more information on that, go back to the neurology section where I talk about that in greater detail. For diagnosis, when myasthenia gravis is the suspected diagnosis, assuming the patient is stable, which there may be concerns with that because if this is really severe, you can have respiratory compromisation. The best initial diagnostic step is going to be a serum anti-acetylcholine receptor antibody titer. So the problem with myasthenia gravis is that you're getting an autoimmune antibody that is targeted towards the acetylcholine receptors, which of course we need our acetylcholine receptors to allow for contraction of muscle. So if you have this competitive inhibitor antibody sitting on the receptor site, then you're not going to be able to contract your muscle as usual, and so that's going to manifest as weakness. This is, and I can't help myself from going into the differential here, this is different from Lambert-Eaton syndrome, where the offending agent is an antibody to the voltage-gated calcium channel. So, like this question implied, this should always be accompanied by chest imaging, both AP and lateral chest imaging, to rule out a possible associated thymoma. And the reason that lateral chest x-ray is so important, if you go back here, the thymoma, if it's small enough, and this is a really big thymoma, but if the thymoma is small enough, it can actually hide behind the great vessels. And so you may not see it, and then you might just see, okay, this patient doesn't have a thymoma, I don't need to take anything out. But you don't want to do that, because if the thymoma is small and it's hiding, you'll only see it on lateral chest x-ray. So that's why you've got to get the lateral chest x-ray. It's a good rule of thumb to always get a lateral chest x-ray in addition to your AP chest x-ray. You should never just order one alone. The most accurate test for diagnosing myasthenia gravis is an EMG. All right. So treatment for myasthenia gravis for the stable patient, you can use acetylcholinesterase inhibitors. That's just going to give you more acetylcholine to compete and hopefully outcompete the antibodies. So you can use pyridostigmine, ribostigmine, neostigmine, etc. There's multiple different drugs. They're all acceptable. Just know you need to use an acetylcholinesterase inhibitor. If the patient is under 60, treatment should also include thymectomy, no matter what, regardless of whether they have a thymoma. If they're older than 60, you're only going to remove the thymus if there is a thymoma. Most patients will respond to the acetylcholinesterase inhibitors. However, if they don't, then you can go ahead and administer steroids. Myasthenia gravis often waxes and wanes in the course of its severity. So some patients who are controlled on acetylcholinesterase inhibitors may have lapses in their syndrome where their symptoms get worse for a short period of time, and so in those patients we'll administer short-term steroids. We prefer, and this is for pretty much anything where we're administering steroids, we prefer that the steroids be a short term. We don't want to administer steroids long term because you have complications from that. So if they are a patient that's not responding to acetylcholinesterase inhibitors, uh, and you have to have them on steroids very frequently, then what you would then do is switch them to a steroid-sparing agent, which is an aptly named class of drugs that you can give instead of steroids. And those would include drugs such as azathioprine and cyclosporine. Aminoglycosides are often associated with neuromuscular weakness, and these can worsen or precipitate myasthenia gravis symptoms. So if a patient has ever been diagnosed with myasthenia gravis, if you're giving them an antibiotic, you may want to try to avoid aminoglycosides if at all possible. So here's a woman with myasthenia gravis. What we administered to her is edrophonium, tensilon. This used to be a test that you could do, and I mean you can still do it, but it's not the best test to do. And what the edrophonium, the tensilon is it's a basically a medication that is a short-acting acetylcholinesterase inhibitor, I believe. And what it does is it allows for transient improvement of the symptoms. So here she is with her myasthenia gravis. We administer the tensilon, and now she's back to normal. Great. But the problem is this is only going to last for a little bit, and then she's going to go back to this, unfortunately. So she is going to need to be treated in some kind of long-term manner. Question 28. A 61-year-old female presents to your clinic complaining of vomiting and difficulty swallowing. She says that over the past 2 weeks, she's felt like food has been getting caught up in her throat, causing a heavy feeling in her neck. She says that occasionally she'll vomit her food back up, and this somewhat relieves the heavy feeling in her neck. Before you begin your physical examination, she decides to kindly demonstrate her ability to retrieve recently eaten food from her throat. You note undigested food, an extremely malodorous food product. So this is not food that was in the stomach, this is something that was in the throat. It's not digested, and it really, really, really stinks. Which of the following surgical procedures will most likely be of benefit to this patient? A. Pneumatic esophageal dilation. B. Cricopharyngotomy. C. Esophagectomy. D. Hellermyotomy. Or E. Surgical intervention is inappropriate in this patient. Alright, so some time to pause it here. And the answer is B. So this is a patient with Zenker's diverticulum, and we can be relatively assured of that, even though we are still going to do a barium swallow to, we would never go straight into surgery from here. We're still going to do a barium swallow to affirm our diagnosis. But based on what you know from this, if you're asked what surgical procedure is most likely going to benefit the patient, you should know that, okay, she's probably got Zenker's diverticulum. What do I do for Zenker's diverticulum? I do a cricopharyngeal myotomy, or a cricopharyngotomy. So these other tests are used for other things that can cause dysphagia. Pneumatic esophageal dilation can be used for esophageal strictures and webs. Esophagectomy can be used for esophageal cancer, which also can cause dysphagia, and a Hellermyotomy is used for achalasia. All these things cause dysphagia, but that's likely not what this patient has. And the reason that's likely not what this patient has is because her food is getting caught up in her neck. She's got the heavy feeling in her neck, and she's able to express the food from her throat. That's really gross, but it's an important diagnostic or an important symptomatic feature, because this makes it consistent with a Zenker's diverticulum. Other things that you'll see in these patients are halitosis, and a lot of times the patients may even come in presenting with halitosis. This is their chief complaint: is I've got bad breath and I don't know where it came from. Yeah, this has only been going on for the last couple of years. I haven't had bad breath all my life. It's just recently. And so if a patient ever comes in complaining of bad breath, Zenker's diverticulum should be on your differential, because it can be a cause of acute halitosis, for lack of a better term. So here's a Zenker's diverticulum. We would never operate on this patient, and I don't want you to think that we're going straight in for a cricopharyngotomy just based on what this patient has on her history, symptoms, and physical. But this cricopharyngotomy is the surgery you're going to eventually do if she has a Zenker's diverticulum. The best next step, however, in this patient is going to be a barium esophagram. And the barium esophagram will illustrate very beautifully the outpouching of the Zenker's diverticulum, which is caused because the esophagus outpouches, diverticulates through a weak part in the cricopharyngeus muscle. So this is a false diverticulum. It's herniated through a weak portion of the cricopharyngeal muscle in the neck. Classic presentation is dysphagia with regurgitation of undigested food. And like I said, usually it smells really bad because it's been rotting there from bacteria. History, typically the patient's older, 55 plus. Sometimes they've had a history of aspiration pneumonia just because of the chronic regurgitation. Symptoms are going to include dysphagia, of course, regurgitation. So even though this patient said she's been quote-unquote vomiting, she hasn't been vomiting. She's been regurgitating. And the difference between vomiting and regurgitation is that when you have regurgitation, it's undigested food. When it's vomiting, it's acidic, you've got stomach acid in it, and it's digested food usually. So halitosis can be a presenting symptom as well. A patient is sometimes able to manipulate their neck and regurgitate the food, and that's just because they've had this neck heaviness from the diverticulum, and when a patient's sitting around and they got this heaviness, they're going to try to do whatever they can do to get rid of the heaviness. And so sometimes you can manipulate your esophagus from the outside and get the food regurgitated on your own. It sounds terribly gross, but the USMLE wants you to know this. Diagnosis, best initial diagnostic step, like I said, is a barium esophagram. And so you'll have them swallow the barium contrast material, and you'll find the little outpouching in the neck. And you'll take pictures of this as it's going down. What you'll also see then is even after the barium has passed the proximal esophagus, you'll continue to have barium in your diverticulum. And it's the same reason, like when you eat, you swallow the food. Yes, some of the food gets down into your stomach, but some of it gets caught up in the diverticulum. The treatment is a cricopharyngotomy, also known as a cricopharyngeal myotomy, pretty much the same thing, usually with resection or stapling of the diverticulum. So you got to either cut the diverticulum out and staple it, or just staple it. It depends on the surgeon. You don't need to know when to do one or the other. I don't even know. So cricopharyngeal myotomy here, you do an incision in the cricopharyngeal muscle. This will reduce the herniation, because what you've done here is you rather than having this little weakness, now you've got a big weakness. And in a big weakness, you're not going to herniate as much because it's a larger weakness, and the thing that drives the herniation is the pressure gradient. And so if you have a little tiny weakness, the pressure gradient is going to push the organ out. If you've got a larger weakness, then you've got more of an equalized pressure, and so that's going to reduce the amount of herniation. Usually after this, the herniated portion is removed or stapled. Complications from this, of course, anytime you're instrumenting, manipulating the esophagus, there's a risk of perforation, usually quite low, but it's going to be a higher risk than if you were to just do your typical EGD, where it's usually less than 1%. You can also get a recurrent laryngeal nerve paresis or paralysis because it runs kind of in this area. So here's your list of different things that can cause dysphagia. Remember, very important, when you have a patient who has dysphagia, the number one question that should come off of your mouth is this dysphagia, is this difficult eating just solids, or do you have difficulty eating both solids and liquids? If it's just solids, it insinuates that there is a problem mechanically. If it's both solids and liquids, it will insinuate that you have a problem with peristalsis. Question 29. A 57-year-old male presents to the ED via EMS after suffering an episode of massive hematemesis at the local bar. His only past medical history on file is a hospitalization 2 years ago for acute edematous pancreatitis. Routine laboratory examination is remarkable for a hemoglobin of 9.1, ALT of 140, AST of 205. IV fluids were started in the ambulance, and he's currently receiving a bolus of normal saline. His airway is secure and he's vitally stable. Nasogastric suction is secured. Which of the following interventions would be the most appropriate next step in the management of this patient? A. Upper endoscopy or EGD. B. IV propranolol. C. Placement of a single-stick and Blakemore tube. D. Urgent transjugular intrahepatic peritoneal shunting or TIPS. Or E. Urgent portosystemic shunting. Alright, so the answer to this question is A. An upper endoscopy. So we have a patient here with bleeding esophageal varices. Now, his history is significant for the risk factors that would put you at risk for esophageal varices, in as much as he is likely an alcoholic based on the fact that he has had acute edematous pancreatitis, he was discovered at a bar, and that he's got an AST greater than his ALT while they're elevated. So all of those are consistent with I mean, not everybody that's at a bar is an alcoholic by any means, but when you look at his history and his labs, they're consistent with possible alcoholism. And alcoholism would cause you to get esophageal varices. And esophageal varices are a very common cause of hematemesis. So all of these are consistent with esophageal varices. So since we know that that's one of the most likely diagnoses, and it's not just a likely diagnosis, but if it is the diagnosis, it's really, really, really important that you are treating it. So even if this was down towards the middle or the bottom of the diagnostic possibilities, you may still want to do the upper endoscopy, because if you don't, the patient is more likely to die. So the upper endoscopy is going to be done to do banding, ligation of the varices. Other things that may come along in the treatment of a patient with varices may include IV propranolol. So IV propranolol, or just propranolol in general, would be appropriate for a patient who has varices but has never had bleeding varices. So propranolol, beta blocker, helps prevent the first bleeding episode of a patient with varices. But if the patient has already had bleeding varices, it really doesn't do anything. The Sing-Stick and Blakemore tube is useful if you can't stop the bleeding via your upper endoscopy. Then you can temporarily place this tube while you consider more invasive surgical management. And then the more invasive surgical management would be appropriate in this patient, maybe in the long term, but for right now, we need to do an upper endoscopy to try to get these varices stabilized. So ruptured esophageal varices are just dilated esophageal veins. Usually they present as a massive hematemesis. In a patient with long-standing liver problems or alcoholism, there's a significant mortality rate. So like I said, even if ruptured esophageal varices are in the middle or towards the bottom of your differential in a patient with hematemesis, you still are going to keep that index of suspicion and probably go ahead with an EGD anyway, because if that was the problem and you didn't treat it, patient's probably going to die, and now you've got a medical legal problem on your hands. And if you are not from the United States, you should be aware that lawyers are abound in this country and they love to sue doctors. The history surrounding ruptured esophageal varices are going to be consistent with the cause of esophageal varices, so alcohol abuse, possibly IV drug use, which would cause hepatitis, and that can be another cause of the portal hypertension that can lead to esophageal varices. Cirrhosis of the liver, and then just any liver disease in general, which can disturb the parenchyma and cause portal hypertension. Symptoms include melena plus or minus hematemesis. Occasionally, you have a patient with a ruptured esophageal varus that's ruptured but bleeding very slowly, and so they're not going to throw up their blood. It's going to come out in their feces as melena. So a patient with melena, you can also consider ruptured esophageal varix, even though it may not be a pressing emergency at this time. But if it's hematemesis, it's a pressing emergency, like it was in this patient. You should look for signs of liver failure. So those things include scleral icterus, jaundice, ascites, spider angiomata, hepatosplenomegaly, gynecomastia in men. Remember that the liver is responsible for getting rid of estrogen, and so if your liver is diseased, then you're going to have a higher estrogen level, and this results in gynecomastia in men. Symptoms of chronic anemia can be present because they have chronic disease and also because they are bleeding. Patients with severe acute blood loss can present in shock. This patient, thankfully, did not present in shock, but some may. And so in that case, even before you do your EGD, you're going to need to stabilize them. That's going to be your initial step. Labs that are useful for esophageal varices that you'll want to have ordered are your CBC. That's to look for anemia. In this case, it's more than likely going to be a iron deficiency anemia because they're flat out losing blood. You'll want to have a CMP ordered. Note that I say CMP here and not BMP. The CMP is going to include your liver function tests. And that's important because we want to see, is there a diseased liver? If there's a diseased liver, then esophageal varices is more likely. So you'll see an elevated AST and ALT, often with a higher AST to ALT ratio. The high AST to ALT ratio points you towards not only this is a liver problem, but this is a liver problem because of alcoholism. You may also see an elevated ammonium, and the PT can be elevated, and those are both associated with liver failure. For diagnosis, EGD is the best initial step in diagnosis when you have a patient with actively ruptured esophageal varices. Treatment is going to be administration of octreotide, which you could have been doing in this patient, but more importantly, endoscopic correction of varices, which can include sclerotherapy or rubber banding. TIPS or portocable shunting are second-line therapies. A lot of times, though, you can't get the patient sent straight off to surgery right away, especially if it's in the middle of the night. So in the meantime, what you can do is place that tube. There's two different kinds of tubes, the Sengstick and Blakemore tube, which is more common. There's another tube called the Minnesota tube. Both of those are appropriate to be used you're basically stopping the bleeding by applying direct pressure. That's basically what those tubes do. But you can't have those tubes in for very long, so eventually the patients will have to go off and get surgery. But the first step for bleeding esophageal varices is remember this, stabilization, and then EGD for endoscopic correction. So here's a bleeding esophageal varix. If you see this on endoscopy, then you'll just go ahead and either rubber band it or you'll sclerotherapize it. I don't know what the best word is there. Sclerose it. Here's another one. Very obvious. You got this like waterfall of blood coming out and this tortuous looking vein here. You see more tortuous looking veins here. Those ones aren't bleeding, but this one is. And so you'll go ahead again and try to rubber band it. Okay, so finally, question number 30. A 36-year-old male who works as a construction worker presents to your clinic complaining of a bulge in his abdomen, which he's noticed for the last couple of months. He's generally in good health, but had an open appendectomy 2 years ago. On physical examination, you note a 2-centimeter mass at the level of the left inguinal ligament. The mass is only palpable and visible when the patient coughs or strains, and then spontaneously regresses afterwards. With gentle invagination of the left scrotum, you are able to feel a mass at the tip of your finger with straining. There is no associated pain with this mass. Abdominal examination is otherwise normal. Which of the following is the most likely cause behind this mass? A. Heavy lifting and straining. B. Recent surgery. C. Relatively wide pelvic structure. D. Patent processus vaginalis. Or E. Lymphadenopathy. It's really loud. I'm sorry. I've got these really obnoxious motorcyclists, neighbors driving by my house. Okay. So this question requires you to not only know what is the likely diagnosis in this patient, but also what the cause is behind that most likely diagnosis. Or I should say, the most likely cause behind the most likely diagnosis. And this is important because you should know what the causes of these different hernias are. So the answer to this is D, patent processus vaginalis. So based on this patient's age and his uh, his symptoms and the physical examination, we can diagnose him presumptively with an indirect inguinal hernia. So first off, he's 36. So younger men, men in general, but younger men tend to get indirect inguinal hernias, whereas older men tend to get the direct inguinal hernias. So that having been said, on physical examination, you've got a palpable mass that's present when he coughs and strains, but then it regresses. So what we know about that then is that it's probably a hernia. It's not lymphadenopathy, because if it were lymphadenopathy down there, and you do have a lot of lymph nodes down there, but if it were lymphadenopathy, you'd be able to feel it the same way all the time. It wouldn't come out and go back in, and come out and go back in. So we can get rid of E just based on that. Another thing here is that, and this is really what solidifies the diagnosis here, even though we'll probably need to get imaging, what really makes this, apart from his age, what really makes this almost certainly an indirect inguinal hernia is that when you do your physical exam, and you should always do this in a patient with a possible hernia, when you do the invagination of the left scrotum, and all you're doing is gently pressing your finger, your examining finger, up into the scrotum and into the superficial inguinal ring, which is the exit of the inguinal canal. Just gently placing it up there, and what you're feeling for is the hernia. And it's going to feel different if it's an indirect or a direct inguinal hernia. So you've probably placed your finger to the superficial inguinal ring, or maybe a little bit past there, it doesn't matter. You've placed your finger there. If it is, and let's look at this picture here, this will help. So if it is an indirect inguinal hernia, what you have with an indirect inguinal hernia is a projection through the inguinal ring. So eventually, if it goes far down enough, the hernia is going to exit the superficial inguinal ring and go into the scrotum. So when you feel when you've got your finger stuck up into the inguinal canal, transscrotally, you'll feel the tip of the hernia against the tip of your finger. If, on the other hand, it was a direct inguinal hernia, which rather than projects through the inguinal ring, projects through the abdominal wall, you'll feel the hernia against the side of your finger. So in this case, the pads of your finger, either the pad of your finger or like your fingernail area, but it won't be on the tip of your finger. So just think of, all you have to think of for that is how your finger is positioned. Your finger is positioned parallel to the inguinal canal. So if you have an indirect inguinal hernia, it's going down the inguinal canal, so it's going to push up against the tip of your finger. If it's going through the abdominal wall, it's going perpendicular to the inguinal canal, and so it's going to press up against the pad of your finger or your fingernail, depending on how your finger is positioned. So that's going to help with the diagnosis just based on the physical exam. But in general, with indirect inguinal hernias, they tend to be younger men. With direct inguinal hernias, they tend to be older men. So, cause behind this. The indirect inguinal hernia is most commonly caused, even though it can be idiopathic, most commonly it's caused by a patent processus vaginalis. The processus vaginalis is sort of this little opening that exists in the developing fetus, and roughly around 3 months of gestation, the processus vaginalis goes away, it obliterates. And so, since that closes off, then you no longer have a patent processus vaginalis. But if it doesn't close off, or it doesn't close off enough, then it's a patent processus vaginalis, and that puts you at significant risk for an indirect inguinal hernia. So the other possible diagnoses, but less likely, are the direct inguinal hernia. That is most commonly caused by having heavy lifting and straining, just in general, though, due to weakening of the musculature and connective tissue in that area. So that's why it's more associated with older men and associated with men that are doing heavy lifting, especially older men. So even though this patient works as a construction worker, we don't often see direct inguinal hernias in younger men. So this patient's more likely to have the indirect inguinal The recent surgery, which would cause possibly an incisional hernia, is not the case here. Even though he did have a recent surgery, the open appendectomy, this is on the left side, and remember that the appendectomy, you're going to be making your incision on the right side because that's where your appendix is. But furthermore, this mass is down by the inguinal ligament, and if you had an incisional hernia at an appendectomy site, it would be above the inguinal ligament where your appendix is. The relatively wide pelvic structure, remember who has relatively wide pelvic structures? Women, because they have to be able to give birth. And the relatively wide pelvic structure is what puts the women at risk for femoral hernias. But in a man, femoral hernias are less likely. Okay, so based on the history, the symptoms, and the physical examination of this patient, indirect inguinal hernia is most likely, and the most common cause of an indirect inguinal hernia is a patent processus vaginalis. Okay, so if you'll do yourself a lot of favor, both for the USMLE and especially for clinical practice, to know how to do this palpation. It'll help you be able to solidify your diagnosis of whether it's an indirect or direct inguinal hernia prior to going in for imaging. The patients will still have to go in for imaging. We very rarely do a surgery unless it's emergent without imaging, but this will really help you making a presumptive diagnosis before you do the imaging. And I guarantee you the USMLE will want you to know that if you feel the mass on the tip of your examining finger, then it's probably an indirect inguinal hernia, versus if you feel it on the pad of your finger, it's probably a direct inguinal hernia. Okay? If you have any questions, feel free to let me know.